The broadcast is now starting. All attendees are in listen-only mode.
Welcome. Today's webinar will focus on appropriate opioid prescribing. I'm Margene Searcy, Director of the Central Rockies Addiction Technology Transfer Center, or ATTC. The ATTCs are comprised of a national network coordinating office, 4 national focus areas, and 10 regional centers. For today's housekeeping, all participants will be muted for the duration of the webinar. For the best sound quality, please use the call-in number provided and mute the speakers on your computer. For technical assistance, you can contact Shannon Christensen. Shannon's information is listed on the slide. You can also use the chat feature at the bottom of the screen to ask a question during the presentation. With time permitting, we'll address those during the webinar. Otherwise, attempts will be made to follow up by email post-webinar. This webinar is being recorded. The URL will be posted to the Central Rockies ATT website on September 1st. A copy of today's PowerPoint presentation is in the handout section on your webinar toolbar. Also, in this section, you'll find the instructions on how to complete the post-webinar test to receive your continuing education. These instructions will also be available on the Central Rockies ATT website under Continuing Education. Your moderator for today's webinar is Captain Christina Mead. Dr. Mead.
Good morning and good afternoon, everyone, and welcome. My name is Dr. Christina Mead, Regional Pharmacy Consultant for Health Resources and Services Administration. Thank you for joining the Region 8 Public Health Learning Series entitled Strategies to Address Opioid and Prescription Drug Misuse. This is the third session of a 5-part webinar series brought to you by a collaborative effort from the Central Rockies Addiction Technology Transfer Center and the Denver Regional Offices of Health Resources and Services Administration and the Substance Abuse and Mental Health Services Administration. At this time, I would like to specifically thank and acknowledge my colleagues, Dr. Kim Patton from HRSA and Dr. Charles Smith, SAMHSA Regional Administrator, for making this series a success. The goal of this 5-part learning series is to increase our knowledge and practical skills related to safe clinical practice guidelines for prescription medications, the clinical treatment of addictive disorders, and the use of naloxone for opioid overdose. Today is our third presentation of the series focused on appropriate opioid prescribing. The presentation will focus on a multidisciplinary approach to safely and effectively managing chronic pain. However, before we get started, I would like to remind everyone that if you would like to ask a question during the presentation, please use the chat feature at the bottom of the screen. Time permitting, questions will be addressed during the webinar. Otherwise, attempts will be made to follow up by email post-webinar. At this time, I am excited to introduce our speakers today. All of our speakers for this session come from Sheridan Health Services, a community health center located in Denver, Colorado. At this time, I'd like to introduce Dr. Emily Cheshire, former medical director and family nurse practitioner at Sheridan Health Services. Currently, she's the CEO and nurse advocate consultant for the Center for Personalized Education for Physicians. Secondly, I would like to introduce Jennifer Manchester, family nurse practitioner at Sheridan Family Health Services. Next, I would like to introduce Mary Kay Mensner, Behavioral Health Program Director at Sheridan Health Services. And lastly, Dr. County Valdez, Associate Professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences and Clinical Pharmacist at Sheridan Health Services. With that, Dr. Cheshire, you may begin.
Our topic today is going to cover appropriate opioid prescribing. Managing Chronic Pain in a Federally Qualified Health Center. Our take-home points today, the 3 points that we'll hope you will leave with, is that it's key to develop a structured chronic pain management program. This is important to eliminate variance of chronic pain management between providers and to avoid both internal and external provider shopping. An interdisciplinary team improves safety and provider satisfaction. And lastly, providers, you are never obligated to prescribe a controlled substance. If the appointment is uncomfortable, you may always advise the patient to return to readdress. And we'll discuss some strategies around this as we go through. Our outline for today will provide a brief introduction to our clinic, Sheridan Health Services, discuss some opioid use and misuse, some common concerns regarding managing chronic pain in primary care, but also why it's necessary, benefits of a structured interprofessional chronic pain program, an overview of the VA Department of Defense guideline, and then Sheridan Health Services chronic pain management program that's based on this guideline. And the parameters, here you'll see the points that we will cover around the Sheridan Health Services chronic pain management program. Finally, we'll conclude again with the take-home points and an overview of the next webinar. Sheridan Health Services is a federally qualified community health center in partnership with the University of Colorado College of Nursing. We are an interprofessional team and we embrace an integrated care model. Listed here are the types of providers and support staff that we use at the clinic. Our patient population primarily serves uninsured, Medicaid, and Medicare, and we have a unique partnership with ARTS patients. ARTS stands for the Addiction Research and Treatment Services, who are patients with a history of addiction who have come through the legal system, and while they're in their treatment for addiction, we are their primary care provider. What we should know about opioid use and misuse. Each day, 44 people die from prescription pain medication overdose in the United States. In Colorado alone, there are 50 drug overdoses each month, and 35 of these are for prescription pain medication. Overdose deaths have quadrupled in the United States since 2000, with no decrease in perceived pain. And in the United States, more people die from prescription drug overdoses than from car accidents or street drug overdoses. So what are some of the common concerns around managing chronic pain in the primary care setting? First, providers may feel they lack adequate training to treat chronic pain. This is like anything. If you're not prepared, you're uncomfortable. Patients may consume large amounts of time. These patients may be perceived as challenging. There are also liability concerns and specifically fear of accidental overdose using some of the controlled medications. The polypharmacy is a concern, and dangerous drug combinations such as narcotic medications mixed with benzodiazepines. Lack of addiction referral services. And ultimately, providers may feel uncomfortable managing patients when misuse, abuse, or addiction is suspected. However, chronic pain management is a necessary service. Why is that? The Institute of Medicine estimates that 100 million Americans suffer from chronic pain. In FQHCs, this population traditionally has an access to care issue. If we don't treat their pain, who will? We are the safety net providers for this population who historically have minimal access to specialty care. Self-medication becomes an issue. Unmanaged chronic pain patients may result to purchasing drugs on the street or using alcohol. For example, almost a third of Coloradans report taking pain medication prescribed for someone else. There are safety concerns here that are improved when a formal pain management program addresses these needs. This pain management program may not necessarily include opioids, and we'll discuss more about that. Doctor shopping or provider shopping is an inconsistent care is a problem. This is a typical case that we see in our clinic where a patient may present to care. They've been transitioned post-surgical or from a workman's comp issue. They've been discharged from specialty care, and then they've been on long-term pain medication. They're presenting to us to return to established care with our primary care clinic. And when we did not prescribe opioids, oftentimes the patient would present to the emergency room with acute pain and quickly gets labeled as drug seeking. Now, this doesn't mean that we immediately prescribe their narcotics and bridge what medications they've already been on for some time, but it does mean that we have a responsibility to assess and develop a plan of care that may or may not include controlled substances. The next point here is a decrease in function and productivity as well as quality of life. Cost to society is $560 to $635 billion for medical care and lost workdays. So this is a societal issue. Ultimately, we can do it safely, and an interprofessional model is superior. The benefits of an interprofessional chronic pain program: provides comprehensive pain management, a decrease in provider burnout and burden. It increases treatment options for your patients, provides patient and provider support. It improves safety, and it improves safety through a formal process for double-checking prescriptions, input from multiple disciplines, and this facilitates the ability to stay current on literature and new guidelines as well as best practices. And ultimately, it promotes consistency of care. The take-home here is that no matter what type of program you choose to treat chronic pain, it should be well-developed, in writing, and clear to all care team members, and clearly communicated to patients. Taking time to develop a program before initiating chronic pain treatment will save lots of time and headache on the back end. We've learned from mistakes but have developed a successful chronic pain treatment model, which we will go into further detail about. But first, we'll discuss the guidelines that we use to develop our chronic pain management program.
Even though chronic pain management is a necessary service, many providers are not comfortable managing chronic pain. This is where guidelines can be very beneficial. I'm going to review the Veterans Affairs Department of Defense's guideline, as it is a comprehensive clinical practice guideline which is used by many practitioners. During the evaluation process, the guideline recommends that patients receive a comprehensive history and physical examination, which includes a general medical history with additional focused assessments. These assessments include assessment of past psychiatric history, such as depression, anxiety, other emotional disorders, risk of suicide, and previous suicide attempts. Assessment of medications, which includes effectiveness, side effects, and tolerability of both current and past analgesics, as well as drugs which may interact with opioids. Assessment of substance abuse history, which includes not only personal but as well family and peer substance abuse, as a patient may be at risk for sharing opioids with peer and family members. Assessment of mental status examination, which includes level of alertness, as well as the ability to understand and follow instructions. Assessment of diagnostic studies and assessment of occupational risks and ability to perform job tasks. Information from the pain history and physical exam then should be reviewed to ensure that the patient has had an adequate trial of non-opioid treatments. A urine drug test should be used to screen for the presence of illegal drugs, unreported prescribed medications, or unreported alcohol use prior to starting therapy. Patients on chronic opioid therapy should be assessed for suicide risk at the onset of therapy and regularly thereafter, as high suicide risk is a relative contraindication for opioid therapy. Intensity of pain should be measured using a numerical 0 to 10 rating scale to assess current pain, average and least amount of pain in the last week, as well as the reduction of pain intensity after taking pain medications. Opioids should only be used after careful consideration of the risk and benefits. For treatment and management of chronic pain, the guideline recommends that patients and families receive education regarding various treatment options. The patient and provider should both sign a written opioid agreement, which defines the responsibilities of the patient and provider. The provider should select appropriate opioid therapy based on the ability to adequately relieve pain at the lowest effective dose and with the fewest adverse effects. The provider should provide timely, accurate, and thorough documentation of drug therapy, which is in compliance with the Federal Controlled Substance Act. Assessment of patient status and response to therapy is performed and includes assessment of efficacy, adverse effects, and patient adherence. And when needed, drug therapy is adjusted to minimize patient harm, manage side effects, and improve adherence. The guideline recommends discontinuation of opioid therapy in cases of severe, unmanageable adverse effects, non-adherence to the treatment plan, or unsafe, criminal, or dangerous behaviors, misuse suggesting addiction, lack of efficacy, or if the patient wants to discontinue therapy. The guideline additionally recommends a referral to an addiction substance abuse specialist or specialty care, and that long-term surveillance is maintained. Lastly, the guideline recommends that high-risk populations are managed appropriately, and those would be such populations, maybe substance abuse or patients who have sleep apnea. The chronic pain management model at Sheridan Health Services includes providers, behavioral health clinicians, clinical pharmacists, nurse, medical assistant, and pharmacy students, and is based on the VA Department of Defense's guideline. When developing our model, we worked collaboratively to develop the standard operating procedure, curriculum for shared medical visits, methods to ensure patient safety, patient-provider expectations, forms to use during the pain visits, standards to consistently document chronic pain visits, and an interprofessional team to address patient concerns. We have implemented several parameters to ensure safe prescribing, which includes no narcotics on the first visit. We feel that opiates are not initial treatment options for chronic pain, and other medications should be tried first. We calculate and document the morphine equivalents at every visit, with a maximum of 120 morphine equivalents prescribed to patients. Opioids will not be prescribed for conditions which lack support from the literature, such as fibromyalgia. We perform urine drug tests at baseline and then randomly, at least 2 times per year. And we perform PDMP at every visit. Because naloxone can temporarily reverse an overdose until an ambulance arrives to the patient's house, it is an important aspect of treatment. We provide a naloxone prescription to the patient and provide education to the patient and family or household member on when and how to properly use naloxone. Opioids will not be prescribed for patients who are also taking benzodiazepines due to the serious adverse effects of concomitant use, including death. A sleep apnea assessment is performed to ensure opioids are safe for the patient to use. And patients who are receiving chronic opioid therapy more than 3 months are required to complete the shared group medical appointment program within 1 year. Lastly, we require patients to sign a controlled substance agreement annually and attend chronic pain visits regularly. This includes monthly visits for individual appointments and every 2 weeks for shared group medical appointments. If misuse or abuse is suspected, individual appointments may be required every 2 weeks. We also developed a controlled substance agreement. If you notice, this is an agreement, not a contract. A controlled substance contract is a legally binding document, which can increase liability if not followed as written. The agreement is just that. It's an agreement which defines the responsibilities of the patient and the provider. Our controlled substance agreement includes the following. The patient acknowledges that opioid therapy is only one part of treatment. They will only use pain medications as prescribed by the provider and only accept opioids from Sheridan Health Services providers. If opioids are prescribed from another provider, such as a dentist, the patient is responsible for notifying our clinic. The patient agrees to not use illegal or illicit drugs and to participate in random urine screens and pill counts. They will not request early refills, which includes replacing lost, damaged, or stolen medications, and will not request refills by phone or without a scheduled appointment. They agree to adhering to monthly or twice-monthly chronic pain visits and other pain-related appointments, for example, physical therapy, neurology, counseling, etc. They will not share, exchange, or sell opioids, and they acknowledge that the PDMP will be evaluated at each visit. The patient will, following the contract, they will understand that if agreement is not followed, opioids may be discontinued. As long as the patient follows the above, the provider will continue to provide opioids as one of the chronic pain treatment modalities. If the patient does not adhere to the agreement, he or she is no longer a candidate for controlled substances. However, the patient can continue to receive chronic pain management with other treatments and techniques. In addition, the patient is not fired and may still receive primary care from the clinic. Because of patient safety and provider liability, we take the controlled substance agreement very serious. So when a patient breaches the agreement, we do not provide an opioid taper, but rather initiate withdrawal treatment. We are comfortable providing symptomatic withdrawal treatment since we do not prescribe high doses of opioids. Our opioid withdrawal regimen consists of ondansetron to treat the nausea and vomiting, loperamide to treat diarrhea. We do not use benzodiazepines, but rather will prescribe hydroxyzine to treat anxiety, which can also help manage insomnia and nausea and vomiting. And we use clonidine to decrease anxiety, restlessness, dysphoria, and heart rate, as it reduces catecholamine release in the sympathetic nervous system. We also refer patients to an addiction specialist when needed. To ensure patient safety and enhance clinical care and data-driven decisions, we routinely use the electronic medical record and the prescription drug monitoring program, which I will refer to as the PDMP. Prior to every chronic pain visit, either pharmacy or nursing works up the patient. The workup consists of looking up the patient in the PDMP to identify all controlled substances and doses the patient has received. We also use this to evaluate possible misuse, abuse, or breach of the controlled substance agreement, and to determine when the next opioid prescription is due. When we review the electronic health record, we do this to reconcile the opioid dose and the fill date as documented in the PDMP with the EHR. We noticed that some patients were hoarding their opioids. For this reason, we provide new prescriptions based on the actual date the opioid was filled per the PDMP and not the EHR. We calculate the daily morphine equivalents, assess if the annual pain agreement is current or is needed, identify the date of the last urine toxicology screen, and determine if the patient has received a prescription for naloxone. Using a standardized form, any issues or gaps identified during this process is communicated to the provider and then verbally provided to the provider and then recorded in the EHR. It is important to select appropriate medications for the patient based on patient-specific factors and formulary considerations. Each patient will have a pharmacy assessment where a medication therapy management review will be conducted to evaluate the appropriateness and safety of the current regimen, as well as look for additional adjunctive or alternative treatment options. During the pharmacy assessment, patient openness to switching to a long-acting opioid is explored, as patients are often resistant to take a long-acting opioid for various reasons. When a patient is resistant, focused patient education is beneficial, where it can be explained why long-acting opioids are more appropriate and can more effectively control chronic pain than short-acting opioids. Fortunately, in 2014, Colorado Medicaid implemented a 4-tablet per day limitation on short-acting opioids, pushing for a conversion to one of the 3 long-acting opioids on formulary: morphine ER, fentanyl patch, or methadone. It's important that providers receive adequate training when prescribing long-acting opioids, and especially methadone. Methadone is a great medication because of the decreased abuse, but training is important because it has a long half-life with variable pharmacokinetics, and it may be associated with higher rates of unintentional overdose. With Medicaid formulary requirements and focused education, converting patients to long-acting opioids has been easier and more successful at our clinic. To convert patients from short-acting to long-acting opioids, as well as to calculate the morphine equivalents in a consistent manner, a free online calculator through Global RPH is used at our clinic. The advanced opioid calculator additionally provides conversions to methadone. Lastly, during the pharmacy assessment, the need for a bowel regimen is assessed. If a bowel regimen is needed, a stimulant laxative with or without a stool softener or polyethylene glycol is recommended, along with adequate fluids and physical activity as permitted. Because pharmacy students are collaborating and members of the team, we have a chronic pain protocol to ensure consistency when performing the PDMP assessment, identifying possible misuse and abuse, determining the need for a long-acting opioid, converting opioids, calculating breakthrough pain regimens, performing a medication therapy management review, and selecting a bowel regimen.
So the bottom line here is to ensure patient safety, and one of the ways that we do this is by identifying higher risk patient populations. And this is something we recommend that you discuss among providers in your group ahead of time and discuss who is appropriate for primary care management in your clinic and who will need referral to a pain management specialty program. And this really depends on the resources that you have available to you in your clinic. We know there are higher risk populations. In our clinic, when we've had poor outcomes, generally there are patients that fall into one of these categories. And so the guidelines would recommend that you evaluate patients for these higher risk populations and refer them appropriately. So the first condition would be pregnancy. This mainly relates to patients who are already on chronic pain medication who become pregnant. And so to avoid this, an important conversation early on in care for women of reproductive age is to be sure that they're on a reliable method of birth control. But likely those patients are going to be better off managed in a collaboration between OB and pain specialty. Adolescents, of course, is a high-risk population in and of itself, also probably better served in a specialty care. Patients that have restrictive lung disease or sleep apnea are also known to be at higher risk. An evaluation for sleep apnea is part of the assessment that you would do before starting a patient on chronic pain management. If they're well managed with their current regimen, they're using their CPAP effectively, you can do an evaluation using their current settings and just be sure that they're well managed, but they still are going to be a higher risk population, and that's something that you would want to discuss among providers. Another category would be persistent mental illness, anything more than a moderate depression or anxiety. And in our setting, we're lucky to have psych nurse practitioners on staff who can collaborate in care with us. But we have found in the past that this population, particularly if they're receiving care elsewhere, maybe in a community mental health center, it's been difficult to manage medications, particularly they're often taking benzodiazepines, and so this might be a population that you consider referring to specialty care. Additionally, any patient that has a need for high-dose opiates, as we mentioned, we have a hard stop at 120 morphine equivalents in our clinic, and we arrived at that based on review of guidelines, but also because there doesn't seem to be a lot of evidence for prescribing higher than that for non-cancer pain. Patients whose pain is not adequately controlled at 120 are unlikely to be well controlled at 140 or 160. So you end up with higher risk without a lot of benefit. We also evaluate patients for a current substance use disorder or a history of a substance use disorder. In our clinic, because we have a fabulous behavioral health team and a certified addictions counselor on staff, we have some ability here to manage patients with a history of substance use with a little bit more frequent evaluation. But patients that are currently using illicit drugs are better managed in an addiction specialty care. And for us, we have the ability to refer to a higher level of substance use treatment, particularly the ARTS program. Another way to ensure patient safety is by selecting appropriate management for each patient, and part of that is substantiating their diagnosis. This is one of the reasons that we don't prescribe any controlled substances at a first visit, not just chronic pain medications, but also ADHD meds, etc., because it's important to receive the previous records, review imaging results, all of those things. And if the patient doesn't have access to that, then we're going to need to order imaging before we are able to prescribe medication. Another thing is to reinforce, or if they're not using something, recommend pain treatment that's a non-opioid modality. In our clinic, we've had really good success with some topical drug therapy that's on formulary, but it's important that every visit, we reinforce that narcotics are not the only way that we're going to be managing pain. This is a interdisciplinary and multi-modality model. We provide referrals to physical therapy, behavioral health specialists, maybe community services like acupuncture or healing touch, and strongly encourage those as part of their care. It's also important to provide patient education. These are high-risk medications, and I'm surprised sometimes at patients that don't realize, they haven't had that education in the past. So a part of this being able to prescribe these medications is that patients really understand the pros and cons of them and the various parts of the therapy that are going to be prescribed to them in addition to opioid medications. Additionally, we need to identify red flags, and this is one of the reasons that we check the PDMP at each visit to ensure the patient hasn't been, to the emergency room receiving medications from other providers at each visit. So one of the things that has been most successful about our model has been setting clear expectations for patients and providers from the very beginning. So when a patient calls to establish care, they're informed right away by the MA who took their call that they will not be receiving any controlled substances on their first visit. And like I said, that includes, sleep aids, opioids, anything that's controlled. The patient's list of medications is obtained by the MA and given to the RN for review. And the RN will calculate the morphine equivalent using that global RPH web-based calculator. And if the patient is receiving greater than 120 morphine equivalents, the nurse will call that patient back and clearly explain to them that our practice doesn't prescribe greater than 120 morphine equivalents and why that is. It's really about patient safety. The patient is then given two options. They are welcome to come and schedule an appointment for a face-to-face meeting with one of our providers to discuss treatment modalities and other medications that might decrease their need for narcotics, or they're provided with contact information for a pain specialty practice in our area. We have found that patients, particularly who've been in our care and have gone to pain specialty, oftentimes come back. They prefer to receive care in our clinic and are willing to decrease their morphine equivalency down below that 120 threshold to be able to stay in our clinic. Also, as for all new patients, the patient is instructed to bring all of their medications with them to their first visit. So at that first visit, a history is obtained and a targeted physical exam is performed. And I should mention that depending on comorbidities or patient complexity, this may actually be two visits. It may be a regular new patient intake and then a specific pain evaluation. At that visit, medication review and reconciliation is conducted, typically by pharmacy services, before the provider goes in to talk to the patient. And various screening tools are completed, and we're going to go through those on the next slide. In addition to talking about what's happened in the past for the patient, it's also really important to set some goals for the future. So we use SMART goals: specific, measurable, achievable, realistic, time-sensitive. And that helps to put that sort of forward-looking, hopeful kind of spin on our visit. And the patient is also informed about the expectations for our chronic pain program. So they understand that we will only write prescriptions for 1 month at a time. So they will be coming for sure every month to a face-to-face provider visit, and that during the shared medical visits, they'll actually be coming every 2 weeks. So they need to be aware of that and willing to do that, because we will not prescribe outside of a face-to-face visit. We also discuss the role of formularies, which medications are covered by their insurance, what do we have in clinic for patients that don't have insurance, and that does not include, we don't have any controlled substances in our pharmacy. We also talk about pain agreements, highlighting the important points of that, and I actually highlight them with a marker. And we discuss alternative pain therapies and ancillary treatments. So again, it's really important for patients to understand that they're not coming to clinic just to receive a script for Vicodin. They're coming to clinic for a comprehensive pain management. So that's going to include behavioral health. It's going to include chronic pain education and support through the shared medical visit program. It might include acupuncture, breathing exercises, physical therapy, all kinds of other things outside of pharm therapies. And we also take informed consent really seriously. There isn't good evidence to support chronic opioid medications for non-cancer pain. Quality of life is not demonstrated to be improved, and so that's an important part of making sure patients understand their choices. So the forms that we use in our clinic include a chronic pain management program questionnaire, and that's filled out at the first visit, and again annually. It includes a diagram of a body front and back, and the patient's asked to mark the location and quality of their pain. They're asked to complete a pain scale. They're asked about current medications and treatments and past things that they've tried, what the outcomes were. We talk about associated medical history, although of course that's done more in depth during the visit. They're asked to fill out a functional scale, what things are they able to do, and also quality of life instrument, and some goals that they might set for their pain management. We use an opioid risk tool as part of our screening, and a PHQ-9, which screens for depression and suicidal ideation, and a GAD-7, which screens for anxiety. Those two tools are used for all new patients, but we specifically include that in that first visit for pain. We also use an SBIRT, and additionally a COM or a SOAP to screen for substance abuse. And we use a pain belief screening instrument. That's a lot of things for that first visit, and those aren't filled out at every pain visit. We use a PADT, which we've nicknamed the pad tie, for individual visits afterwards. So now let's talk about EHR documentation. We know this is a high-risk group of patients. You saw the statistics at the beginning of our presentation. So excellent documentation is necessary to avoid mistakes, to allow another provider to cover for you, and also to reduce liability. This documentation could be really time-consuming and arduous, or you could build a template into your EHR to help you save time and be consistent and thorough. And so what we would recommend and what guidelines would support to be in that documentation would be, at every visit, the diagnosis, the type and location of pain, and a brief history. If this is in a template, it can carry over to each note. Recommend that functional goals be listed in there and addressed, that each time a pain score, pain assessment is included, and a medication review of their current regimen, and a space, a little box where you can put their current morphine equivalent. You also need to include a statement that the PDMP has been reviewed and is appropriate, and that there's been a patient agreement signed within the last year, and whether or not a patient has received a naloxone prescription if it's appropriate. And so this is something that the family or partner is trained to use. We prescribe an auto-injector, a pre-filled syringe with 0.4 milligrams of naloxone. It's important to find a pharmacy in your area that's willing to stock this, because it's not something that every pharmacy has, but it has been shown to increase patient safety. So this is something that we do in our clinic. We also document the date of the last year in toxicology screen and the results of that, and the date when the next prescription is due. Finally, I want to just mention support systems that we've put in place for both patients and providers. For our patients, we have a shared medical visit program, 6 sessions that we developed using the Care Oregon curriculum, and we're going to talk more about that in just a minute. This allows the patients to have peer as expert and increases their willingness to try alternative or additional things when other patients have success. It's also an excellent venue to share community resources. For example, in our area, there's some sliding scale acupuncture that patients share information about, and also provides group support for patients so they don't feel so isolated and alone. For providers, part of the support system is having clearly defined parameters and standard operating procedures that eliminate gray areas that might make providers uncomfortable. We also have a regularly scheduled integrated care meeting to discuss challenging patients, management issues, solving problems, and it's also a space for all staff members from the front desk to the MAs to the providers to pharmacy to debrief together. This is also where we do continuing education and invite guest speakers to discuss interesting hot topics. Recently, this year, we had a speaker about whether or not marijuana should still be considered an illicit substance now that it's legal in Colorado, and what its role is in chronic pain.
The shared medical visits are based on the Care Oregon Chronic Pain Management Handbook, which includes a group curriculum. Sheridan Health Services used the curriculum with Care Oregon's permission and adapted it to include the expertise of guest speakers with an emphasis on practical application during the group. All Sheridan Health Services chronic pain patients on opioids must complete the Interprofessional Shared Medical Visit, which is the 6-session series within the first 12 months, within the first 6 months of establishing care for chronic pain management. Patients enrolled in the shared medical visits are integrated into the care team, and they establish guidelines for the group. We base this on a 5-finger agreement, where every finger on your hand represents an aspect of interacting to be honored within the group setting. It includes safety, commitment, respect, direct feedback, and fun. Participants determine how late they can arrive or how early they can leave, and acceptable reasons for being late or missing a class. And the only rule that Sheridan Health Services puts out is that anyone missing more than 1 session will need to repeat the entire series. Each shared medical visit is billed as a medical visit, and the shared medical visits happen every 2 weeks until the course is completed, and then participants transition to a maintenance phase with monthly individual interprofessional medical visits. The curriculum for shared medical visits includes 6 sessions and ends with a 7th individual session. The first session is Introduction, Chronic Pain and Combination Therapy, and is co-facilitated by the behavioral health provider and the primary care provider. Shared visit agreements are reviewed and determined. Participants learn how the pain signal works in the nervous system and the difference between acute and chronic pain. We also discuss the specifics of how chronic pain impacts the nervous system and introduce the concept that the human body and mind can act against impacts of chronic pain. Finally, we discuss combination therapy and why a combination of therapies is often needed to adequately manage pain. The second session, Being an Effective Partner in Your Care, is facilitated by the primary care provider. Participants discuss ways to access and partner with the healthcare system. We review aspects of the Controlled Substances Agreement, including practices that increase personal, family, and community safety. And we review the various members of the interdisciplinary team with the patient at the center. The third session is Use of Medications and Dependence. It was originally facilitated by pharmacy, but we changed it because pharmacy now meets one-on-one with participants at each contact to discuss medications and any potential side effects. So now this session is facilitated by a certified addictions counselor, and participants review a handout and talk about the addictive potential of opioid-based medications. The group discusses the difference between physiological dependence and addiction, and participants learn about substance use disorder treatment programs. The fourth session, Identifying and Eliminating Triggers, is co-facilitated by the behavioral health provider and an alternative practices specialist, like a mindfulness practitioner. It covers that pain is an adaptive response and its purpose is to protect us. But sometimes our brain and nervous system get sensitized and the alarm rings even when danger is not present. Participants are introduced to the concept that sensitive nerves can be desensitized by movement, blood flow, and oxygenation. They learn the phrase, motion is lotion, and the concept of pacing. Uptime is how long they can engage in an activity before pain increases 1 to 2 points, and downtime is the amount of time for pain to return to a normal level. We review strategies connected to changes in daily habits like diet, sleep and time management that can decrease their pain experience. Participants do activities led by the alternative practices specialist, and this particular session is very important to do before they do anything with a physical therapist so that participants have the knowledge that movement or discomfort does not necessarily mean tissue damage. The fifth session is turning down the intensity of the pain message. A physical therapist comes to the group. Participants are introduced to a variety of strategies which may include positioning, cushioning, and an introduction to the TENS unit, which is transcutaneous electrical nerve stimulation. Sharon Jordan from the University of Colorado Denver School of Physical Therapy brings pillows, uses brooms to demonstrate posture when vacuuming or mopping, and when appropriate, she has participants demonstrate how they pick up things from the ground and gives them suggestions. She introduced me to Explain Pain by David Butler and Larimer Mosley, and the drawings by Sunyata resonate with many participants. The sixth session, Restoring and Increasing Your Body's Ability to Block Pain Messages, is facilitated by the behavioral health provider and puts healing in the context of countering the stress response. From Explain Pain, a quote, "What is the complete opposite of a stress response? A hearty laugh in a safe place with friends." Participants are introduced to dialectical behavioral therapy concepts and how effective coping strategies to decrease depression, fear, and anxiety can be used to increase mindfulness, joy, and a sense of control. Finally, participants develop a personal plan. They meet one-on-one with a behavioral health provider to develop a 3-month treatment plan by reviewing concepts, activities, and treatments they have tried since starting the group. We focus on SMART goals, and they define 1 to 3 things related to improvement in daily living that incorporate their successes or interests. Goals are then shared between participants and the entire care team so that everyone's on board with where the patient wants to go. Core concepts and components are woven into each shared medical visit with the intention of participants having a notebook or a personal care folder related to managing their chronic pain that they can reference in the future. Everything discussed with the primary care provider when the client established care is reiterated. Before, at the first shared visit, participants are provided with a folder. It starts with a chronic pain management handbook. Participants are also provided with a copy of their original chronic pain management questionnaire, and as they attend sessions, they keep the originals of their homework assignments. The handbook contains basics about acute versus chronic pain, the pain pathway, overview of the shared visit content, the care team contact information, an example of a pain scale, and then a handout that has 150 ways to reduce pain, which includes detailed instructions around deep breathing and stretching. Their weekly homework includes pain logs, and those pain logs are used to increase the care team and the participants' awareness of potential situational pain contributors. Stretching and mindfulness breaks are done every 15 to 20 minutes during the shared sessions. And as we continue to meet, participants are encouraged to lead each other through activities that work for each of them. Sessions were condensed into 90 minutes, 30 minutes for individual one-on-one sessions with both their primary care provider and pharmacy. Participants then have the opportunity to speak with guest speakers privately if they have questions about any of the issues addressed.
So what are some of the trends we've seen in our clinic since implementing the shared group medical visits? We've seen a reduction in no-show appointments, provider shopping, both external and internal, losing medications, early refill requests, incidents of accidental overdose, provider time spent outside of visits, We've noted an increase in controlled substance agreements on file, urine toxicity documented minimally twice a year, prescription and education for naloxone, and patient adherence to appointments and allotted time. I'm going to briefly go over our outcome data for our shared group medical visits, but the take-home here is to define and measure outcomes for your chronic pain program that you build to manage your patients through either an individual appointments or shared group medical visits. And the reason for this is to continually improve your program. Ultimately, you need to answer the question, how do we know that we've been successful, and how can we improve? Some of our outcomes for specific to our shared group medical visits, as of December 2014, 59% of our patients using opioid as part of their chronic pain therapy had completed our shared group medical visit model. Of the 8 patients who completed the shared group medical visit model in September through December, 100% had incorporated alternative pain control techniques. As you can see in this graph, it was a wide variety of techniques, and anecdotally we had one patient who embraced the concept of motion is lotion and began a daily walking group for his entire apartment complex, which not only decreased his pain but enhanced quality of life as well. 87.5% of our patients were able to re-engage in an activity that brings or brought enjoyment into his or her life, and one patient here was lost to follow-up. 87.5% of patients self-reported an increase in knowledge regarding dangers of opioid pain medication. Now, we felt this was really key and one of the main reasons for our shared group medical visits. So we also wanted an objective measure for this outcome. A literature review yielded one tool called the Patient Opioid Education Measure. For short, it was called POEM, and it was published in the Journal of Pain Research in 2013. This questionnaire divided areas of knowledge into 6 domains. You can see one of the domains here in on the graph here. It's prescribing policies, and under that there were 7 items. Now, this tool is meant to be administered orally, and we did have to make some modifications on how we scored this tool moving forward, but it is a useful objective measure. We used it pre and post in our groups. We noted 100% of patients had a documented review of the PDMP in the EMR. 100% of patients had a signed controlled substance agreement on file. And lastly, 100% of patients had documented urine toxicity screens. So other considerations to make your management easier. When prescribing opioids, it's important to have a contingency plan for red flag situations. So plan this out before it happens. Have available a resource list of detox or addiction treatment facilities, some established behavioral health relationships. I understand every clinic doesn't have those internally, but go outside of your clinics and establish those relationships. Withdrawal treatment strategies are important. We've mentioned some specific prescriptions that can be used. An integrated healthcare forum to discuss challenging patients in your clinic. And then Project Echo. I'm sure most of you are aware of Project Echo. It's a video conferencing tool pioneered out of New Mexico that brings primary care providers together with specialists from a variety of disciplines. They do host a monthly chronic pain session where cases can be presented to chronic pain specialists. Colorado rolled out a similar forum in April, and many states have replicated this model. So this is a tremendous resource that I would invite you to look for in your area. And the take-home points, again, to reiterate, the first point is to develop a structured chronic pain program. We've provided an example today that incorporated some guidelines. Secondly, an interdisciplinary team improves safety and provider satisfaction. And lastly, you are never obligated as a provider to prescribe controlled substances. We had a brief training, and some of our providers have used a script that has helped when they've had an uncomfortable encounter, but they're not necessarily, they just need more information and need more time than the appointment times allotted. And they've often used something similar to this. I've had some safety concerns with what we've discussed so far, and unfortunately our appointment time is up. I will be unable to prescribe your opioid medication today, but I'd like for you to schedule so we can continue our discussion and safely partner to manage your pain. I will provide you with some withdrawal scripts until you're able to return to the clinic so we can continue management. And this has really helped alleviate the pressure for providers to feel the obligation to prescribe to patients that are currently on medications. And lastly, if you identify a patient with a potential addiction and you don't have addiction treatment services, you can either write a taper prescription. We've tried this and we didn't have success with taper prescriptions among this population. Mostly what we experienced was that patients continued to take their current doses of the opioids despite it being written as a taper. So rather than using a taper, we moved more to just not prescribing them opioid medication and only writing for the withdrawal prescriptions. These are some additional guidelines and resources. We reviewed the one we used for our program, which was the VA Department of Defense guideline, but these are additional guidelines and resources that you can use and refer to. And lastly, these are the references. We thank everyone for their participation in the talk today.
Thank you guys so much for that presentation and sharing your model with us. I'd like to give our impressions from HRSA and SAMHSA. Throughout your conversation, we were most impressed at how thoroughly and completely your process addresses the whole person in a truly multidisciplinary and dynamic manner. So again, I would like to thank you guys for your presentation. That content was excellent. A few closing comments before we wrap up. I know we're at time. As a reminder, keep in mind you can access the PowerPoint presentation as well as the continuing education information on the handout section of your webinar toolbar. In addition, continuing education information is available at the Central Rockies ATTC website under continuing education. Lastly, keep in mind this series of webinars was recorded and will be available for viewing and available for continuing education in September. At this time, I'm going to give you a verification code for the continuing education. I will repeat it twice. The verification code that you'll need to redeem your CE is 98614. Again, that verification code is 98614. Very briefly, looking at August 12th and August 19th, we have 2 more of webinars in this series. Please register on the ATTC website, and please feel free to invite your colleagues. And we've had a lot of interest in this topic. With that, I have completed my comments. I'll turn it back over to the ATTC.
This concludes today's webinar. We hope that you'll all be able to join us next week.